as we get this started, I guess the first big topic that we wanted to talk about is thrombosis or blood clots, because that's really crucial to all of the MPNs. Blood clots affect about 1 in 5 patients with MPN, and that really is agnostic of whether you have ET, PV, or MF. And that might be a little bit surprising to some of you with MF because it's not something we talk about a lot during the MF visits, right? We talk more about symptoms and risk in terms of progression to AML. But it turns out that blood clots are also fairly common in myelofibrosis as well. And so when we think about blood clots, we have blood clots that can happen in the arteries. So that could be the arteries of the heart, which would be a heart attack, or in the brain, which would be stroke. Rarely does it happen to the arteries in the legs, so that would be like peripheral arterial disease, but it can be there as well. And then we have blood clots in the veins. So those are typically the leg veins, the veins in the lungs, which would be called pulmonary emboli. And then we get weird blood clots that can be in the veins of the belly. And then we can get weird blood clots in the veins of the brain. So, which technically is still a stroke, but it's not in the arteries, it's in the veins. So it's called a cerebral sinus vein thrombosis. So when you have a clot in a vein, you tend to be more likely to get a clot in a vein the second time. If you have a clot in an artery the first time, you tend to be more likely to get a clot in the artery the second time. So the question is, how do we prevent this? So if I've never had a clot, how do I prevent that? Because I don't want it. If I've had a clot, how do I prevent or mitigate my risk of having another clot? When I see patients in clinic, kind of regardless of ET, PV, or MF, again, because the risk of clots is high in all 3 groups of diseases, I first talk about, all right, so what's important to mitigate these risks, and how far do we need to go? What data do we have? So in terms of the risk overall, if I think about a normal, healthy person in the general population, their risk of a stroke, heart attack, blood clot in the legs or the lung per year is roughly 0.6% per year. Somebody with hypertension, diabetes, it's a little bit higher. It's about 0.9% per year. When we think about PV as kind of the classic examples, the low risk PV is generally, on average, about 3% per year, and higher risk is roughly 6% per year. And these numbers vary, right? It depends on like which populations we're looking at. But so from these numbers, you can tell that your risk is substantially higher than the general population, right? Okay, so I'm gonna ask Rupali here. Oh, excellent. So when you're counseling patients about clot risk, what sorts of things are you thinking about as well? Because that's what's going through my mind is 100%. What's the general population, what's your risk, how do I tailor things for you?
I think so. One question or one point that we discuss is making sure that we're mitigating your other risk factors for having a clot, in particular sort of that arterial clot in the form of a heart attack or a stroke. And so I think it's been mentioned a number of times that we sort of, this is sort of like a team effort. And so we talk a lot about other risk factor management in terms of working really closely with the primary care doctor to make sure your cholesterol is being checked, you're making sure you're being screened for diabetes and hypertension, and should you have any of those things, making sure that they're being optimally managed. In addition, sort of, making sure you're eating a good, healthy diet, exercising, and stopping things like smoking and tobacco. So that's sort of one point of discussion, managing your other risk factors. The second point of discussion, I think, is sort of the concept of cytoreduction. So, are you in a category of risk such that we can prevent that first clot and then subsequent, or if you've already had a clot, the subsequent clot by putting you on a cytoreductive agent. And by that we mean something like hydroxyurea or interferon to sort of, if you have PV, keep your hematocrit at goal. If you have ET, lower, your platelet number, even though we also know this comes up a lot, do I have to have a normal number of platelets in order for my clot risk to be zero? And that's sort of another point of discussion, but it's not always linear, but we do know that in ET, being on a cytoreductive agent does definitely decrease that clotting risk. So cytoreduction is another kind of concept. And then I suppose this is maybe a different topic, but if you get that clot, say it's a a deep vein thrombosis or a PE, how long do you stay on anticoagulation? Forever, time limited. If it's an arterial clot, what kind of antiplatelet agent do you need to be on? Is there a role in addition for some sort of anticoagulant? Those are sort of the 4 topics of discussion.
Yeah. And so I'm going to follow up because in addition to the kind of thinking about cytoreduction or more like normalizing your cell counts, aspirin is a huge part of our armamentarium to reduce your risk of clots. And so what's really interesting about aspirin is that there is fairly clear data in polycythemia vera, and it becomes much murkier in terms of ET. And there's really not a lot of data in myelofibrosis. That said, we know that the platelets are overactive in all of these diseases. So the platelets are these tiny little blood cells that are circulating, and if you were to cut your blood vessel, that blood vessel releases this really sticky stuff called von Willebrand factor. It's like really sticky Velcro, and the platelets that are circulating around stick to that Velcro or von Willebrand factor and help seal up the blood vessel. So it's making a small clot there. When the platelets are super sticky, you can imagine that they're getting overactivated, and they might be more likely, instead of just to seal a little plug, to make actually too big of a plug and cause a blood clot. And so there are quite reasonable data showing that aspirin can calm those platelets down. And so a baby aspirin, 81 milligrams, if you're in Europe, 100 milligrams, once a day is generally what we recommend. Some of you may be on twice-a-day aspirin, right? So there's been lots of interesting data come about that especially if you have ET, you are making a ton of platelets in a day, and the aspirin that you take in the morning is effective on the platelets that were around in the morning, but you're making a whole other set of platelets by the evening. And those platelets have not seen aspirin. So you might be unprotected in terms of the effect of aspirin. So for ET, for some patients, we'll do an aspirin in the morning and an aspirin in the evening. So not double the dose at the same time, but spacing it out in the day.
How do you pick that patient? How do you choose the patient who gets 1 in the morning, 1 at night?
That's a great question. So how do we choose who's getting twice-a-day aspirin? So in my practice, it's those with really high cardiovascular risks. They have diabetes, high blood pressure, they're already at risk for heart attack, stroke, or they have symptoms that aren't improving on the once-daily aspirin. So the microvascular symptoms like the numbness, tingling, redness, burning in your hands and feet, which we call erythromelalgia, the migraine headaches that are a little bit better with the once-daily aspirin but not totally better, and so those microvascular symptoms. That's how I usually think about it.
And history of previous stroke also?
So I generally do think about, people with prior TIAs or transient ischemic attacks, mini strokes, I do tend to think of twice daily aspirin for that. Yep.
Another question.
Great.
What happens if you're allergic to aspirin?
Oh, allergic to aspirin. This is a great question. This actually comes up not that commonly, but when it does, it's a big deal. So there are desensitization protocols that can be done. It's kind of painful because you have to take aspirin then every day and not miss any doses ever. For those who are truly allergic to aspirin and don't want to desensitize, occasionally we'll use a cousin drug like Plavix, clopidogrel. So it works on a slightly different pathway. So it's not as great as aspirin at reducing the symptoms, but it can be effective, at least in the general population, at helping to prevent strokes and heart attacks. Great question. 81 milligrams, that's right. So a baby aspirin. So interesting. Do you know why you're on a bigger dose?
No, I did have an MRI and I had some white matter and I've had some stroke symptoms. So I just think that was the go-to.
So in general, the data are, so for 81 to 100 milligrams, because it's Europe, US, that's as effective at inhibiting platelets as higher doses of aspirin. So most generally, we're going to have one in the morning and then one in the evening. Yeah, there are case-by-case instances where we might do slightly higher doses. Yeah.
Does coating for chewable make a difference in aspirin?
Ah, I love this. So there's enteric-coated aspirin that kind of moves the aspirin further down in the GI tract before it dissolves. So to my knowledge, all that does is move where you're potentially going to get the ulcer. So I think the bigger issue is, right, making sure you take it with food and that you are like paying attention to when you're taking aspirin, because you don't want to take it on an empty stomach if possible. You want to make sure you're doing everything you can to buffer the effect of the aspirin on your gastrointestinal tract. Great question. Do you have any other advice that you get?
No, I agree with sort of the instances when you use BID aspirin, baby dose aspirin, as opposed to once daily.
Yeah.
But so we have our
So then I think it's super important here as well. So in addition, so I kind of think about the MPNs as another cardiovascular risk factor, right? So it's kind of like diabetes or high blood pressure, where it's going to be around. We need to manage it to reduce your risk of blood clots. And that's what the hematologist can help with. But your primary care docs, right, are the ones who are really up on the management of high blood pressure and cholesterol. The hematologist, like, I would love to be up on this stuff, but there's just too much other things to keep up with. So it's super important that you partner with your primary care doc to manage your other cardiovascular risk factors. And in particular, there's some newer data suggesting that certain kinds of blood pressure medicines might be better than others in terms of reducing your risk of blood clots if you have an MPN. So the angiotensin receptor blockers, or ARBs, have recently been shown to reduce the risk of blood clotting events. And then there's a lot of interesting work on statins, everybody's least favorite drug. I'm not sure why, right? They're hot, they're cold. People don't love the side effects that you get from statins, but the anti-inflammatory effects and they have pleiotropic effects that tend to be more than just cholesterol. There's some really interesting data on statins and MPNs and the JAK signaling pathway and maybe boosting an interferon response. And so talk to your MPN specialist about these things and then carry them back to your primary care to kind of be carried out. Let's see. The other big things here. So diet, super important, and weight always becomes an issue here. And there's some really interesting data that those patients, the general population who take metformin, or diabetics who get those GLP-1 agonists, the weight loss drugs like Wegovy, Ozempic, there's a lower risk of developing myeloproliferative neoplasms. Really interesting, right? So to my knowledge, there's no data in MPNs that these drugs actually are super beneficial, yet it's really interesting, right? So it's not a problem to be on these drugs, and it's probably pointing us to the fact that we do really need to have good blood sugar control and pay attention to diet, exercise, right? Reduce the inflammatory environment. Okay.
All right. Our next slide was actually one of Dr. Messa's questions, sort of perioperative management in our MPN patients. I think this does come up a lot, and I don't know if there is one, perfect answer. But I think broadly speaking, you know, in your higher risk for blood clotting patients in whom you already, you know, either want them to be on cytoreduction, or if they're on cytoreduction, you want to have kind of blood counts optimally controlled, I think, moving forward into that surgery. So in your PV patients, you want that hematocrit, you know, not just being phlebotomized up and down above and below 45. You want them consistently, you know, below 45 at least. You know, I've had some patients where they've needed some convincing maybe to be on that cytoreductive agent to get them to that optimal blood count control, and they want a knee replacement, and I sort of try to counsel them like, this is a good opportunity to start so that we can really have you on that cytoreductive agent to minimize that sort of post-operative clotting event. The concept of, do I need to hold my cytoreductive agent just from a like wound healing perspective comes up a lot as well. And I will say that typically I tell patients to just continue on through because I don't know that I can necessarily tell, you know, their surgeon or the patient that I'm actually hindering kind of post-op recovery from whatever wound is being created. And so I typically do not hold any of those. In terms of holding aspirin and blood thinning, again, this is a team activity, so I have a conversation with the person doing the cutting to see, okay, what is your kind of surgical risk of bleeding, and you counsel us. And if it would be optimal to hold the aspirin and or, you know, probably obviously the blood thinning medication, the anticoagulant someone's on, then, you know, do so X number of days pre-op, and then, you know, surgeon, you tell me when the optimal time would be to resume post-operatively. So I sort of defer to the person doing the cutting because I think that is, I can't justify, you know, earlier, not interrupting aspirin if it's going to increase risk of bleeding and things like that. I think those are the big things that sort of come up, you know. How do I minimize my risk of blood clotting? Do I need to hold my cytoreductive agent? And then also, you know, kind of piggybacking on how do I minimize my risk of post-op blood clot, is there something special that I need to do in the post-operative setting or the perioperative setting from a DVT prophylaxis standpoint, from an anticoagulation standpoint? And I'll be honest, I typically also sort of have, you know, say it's an orthopedic procedure, I usually counsel people to follow whatever the standard would be. Maybe just being really careful that, you know, in that immediate post-op setting, that if they're in the hospital for 2 to 4 days, they're wearing those SCDs or getting on a, you know, prophylactic dose of, you know, low molecular weight heparin or subcutaneous heparin, and then usually say it's a knee replacement or a hip replacement, just following the surgeon's orders for BID aspirin for X number of, you know, weeks. So I don't usually mess with that part of it, to be honest, because I don't know that we have data to justify necessarily doing anything else.
Yeah, we don't have great data in this space. I take it on a case-by-case basis. So, right, if you have a bunch of risk factors that are all adding up to substantially higher risk of blood clot after like a hip or a knee replacement, then I'll have a conversation with you about maybe you need to be on a blood thinner for 6 weeks or so after, instead of just the aspirin.
There was a question about hormone
Yes.
replacement. I'll get to that, and then maybe we'll go back. So yeah, I think this comes up, literally, I just had a question in my inbox like yesterday. So say in females, so sort of estrogen-based hormone therapy comes up a lot, and I'll start by saying again that in this space also there's really a lack of data. I think that we in general know that hormone replacement is associated with a higher risk of thrombosis. The question is, you know, are MPN patients are even higher risk? And again, there's really a lack of data in this space. I will say, in general, the amount of estrogen that's in like hormone replacement therapy is generally less than that which is in kind of oral contraceptives. So if we're just talking about kind of hormone replacement therapy, I typically recommend that, yeah, you know, I think if say menopause or perimenopause are causing symptoms that are bothersome and interfering with your, daily quality of life, then I usually counsel patients to proceed. There was one published study from Mayo of about 360 patients, females with ET, and they kind of looked to see whether or not patients who are on estrogen-based hormone replacement therapy kind of did that alter their risk of an arterial or venous thrombosis. And in that patient population, estrogen-based hormone replacement therapy did not. They also, in that same study, the cohort of patients who are on OCPs, however, those patients seem to be at higher risk. So if you're just talking about hormone replacement therapy, I usually say, yeah, go ahead, do it. Sorry.
Oh, I just want to ask, I'm so glad you're talking about this because we've been getting people out there talking about it as much as possible. One of the things that we heard was not oral HRT, but either a patch or vaginally.
Yeah, I think there's some data about
there is data about it,
yeah.
and it's very, very good. And we have a lot of patients that call us that say their physician will not let them. And so those symptoms that women have that we always said it was the MPN, the foggy brain, the night sweats, and so on, which are very similar. This is a topic that really needs to be looked at.
Yeah, yeah.
Absolutely. We get it all the time. And we wish there was more data for counseling. And so I take a very similar approach. So I'd really like your cell counts, like your disease, to be under good control right before we add a risk factor for increasing your risk of blood clots. But I generally am not going to say absolutely not. This is a really silly idea. There's a risk with everything. We look at the risk benefit and then mutually decide together that this is an okay path to go down. And then just like Anne was saying, you want to choose the agent that has the least risk in terms of increasing your blood clot risk. And for the oral contraceptives, right, so there are the low estrogen oral contraceptives, there's the no estrogen oral contraceptives, and then we have the alternative for that. So like the vaginal inserts, the rings, those things can also be useful as well. And so very limited data, and this is one of those art of medicine, not the science of medicine right now. Perfect. And then I think testosterone replacement is way more controversial these days, which is fascinating to me because estrogen replacement used to be like the most controversial topic in my clinic. But testosterone replacement, so the data on the risk of increased thrombosis is all over the place. It depends on the publication. In general, when you start testosterone, your risk of a blood clot is highest in the first couple of months. So it's like if you were going to get a blood clot with testosterone, it's going to happen fairly early in your course. But how do you pick who's who? There aren't great, right, defining factors. And testosterone can also increase your hemoglobin hematocrit. So especially if you have polycythemia vera, right, like you got to be in a really good control before I'm going to say that's a great idea. Otherwise, you're going to be sitting in the phlebotomy chair, right? We're going to be up in your hydroxyurea. Like this is a really big issue. And so just like for estrogen replacement, I generally say as low a dose as possible for as short a time as possible, and the preparation also matters. So the pellets have the highest like testosterone burst. The patches and the gels tend to be kind of the easiest in terms of being able to control the testosterone in the system. How do you think about that?
Yeah, same, very similar. Literally, I just got that testosterone question in my inbox. It comes up a ton.
It does.
Yeah, but yeah, it would be nice to have more data
Absolutely.
Hard data. But.
So in terms of when you guys were asking about hormone replacement, menopause, did we hit on the questions that you had?
I think part of the problem is over the years, we've always associated the MPN, like we were talking about earlier. Oh, it's your MPN, it's this, it's that. And the fact of the matter is, I'm not a scientist, and I don't know anything about
Absolutely.
Is it this or is it my MPN?
Exactly. And very hard to tease that out, right? So
Yeah.
without trying something.
That's right.
Yeah, agreed.
Yeah.
So I wonder if maybe we touch on Mediterranean diet since
Sure.
that was brought
Yeah.
up. So
Yeah.
I'll let you lead that one.
Yeah, I think that both from a risk management standpoint and actually from a symptom control standpoint, I think that there is some increasing amount of data about diets that perhaps decrease inflammation, and I think the Mediterranean diet is the one that continues to have the most data supporting it. There's a lot of activity from Dr. Fleischman and her group over in California, supporting that. They did a nice pilot study comparing patients who followed a Mediterranean diet first, sort of demonstrating that it can be followed, that it's a feasible thing for people to actually maintain on a day-to-day basis, and they compared it to folks who were randomized instead to just like a regular USDA kind of diet, and they found that there was a decrease in symptom burden in folks who maintained a Mediterranean diet. And again, I think that there's good data in kind of the cardiovascular literature to support that it helps decrease kind of cardiovascular risk factors, probably superiorly to many of the alternative diets out there.
Yeah, I think this is like the number one question I get in clinic. So I meet patients for the first time and they're like, all right, I hear you. I hear you've got hydroxyurea and all these other medicines, but what can I do for myself? And so it's great to have finally some data supporting a specific diet in MPN. I will say it's not the be-all, end-all. And I think it's kind of common sense in terms of everything in moderation, right? So, and the classic Western diet is not great for health in general. And so thinking about Mediterranean, more healthy oils and fats, leafy greens, right? These are all super important, along with exercise, and thinking about other therapies like yoga, like acupuncture, which I must tell you, before I got into medicine, I thought those things were not useful. I thought it was just a bunch of hooey, like, what were people doing? And I don't know if any of you have ever done acupuncture or yoga, but there is really something to this, right? So there is a big mind-body connection there, and with acupuncture, there is something else going on. I can't really tell you scientifically what's happening, but I can tell you when the needle touches, right, you're not expecting anything, and then they start twisting it, and it gets hot, and you're like, what's going on? These really are active therapies that you can participate in to help symptoms. And not shown here, but one of the things I get all the time from patients that I only see once a year, like I'm consulting on, is, well, they tell me my cell counts are normal, therefore what I'm feeling, the symptoms I'm having, are not related to my disease. That is 100% false. Dr. Mesa, Dr. Grunwald actually did this study showing that it didn't matter if you had perfect cell count control or all of your cells were totally uncontrolled, your symptom burden was essentially the same. So for some patients, right, the therapeutic phlebotomy really helps with a lot of symptoms, or the hydroxyurea really helps with a lot of symptoms, but that's not the universal experience. So really press us if you're having symptoms. It might not be your MPN, right? That's why we have a healthcare team. But it's really important to understand that your cell counts being perfect do not mean that you're not going to have symptoms from the disease. And so looking for other ways then to help with symptoms is super important, and that's why we wanted to bring up the exercise, the yoga, the acupuncture, diet. There's N-acetylcysteine is making another comeback. This is I don't know, the 50th disease we've tried N-acetylcysteine in. We'll see. It works great in mice. I'm not sure that humans are big mice, but we'll see. And then itching for a lot of folks is a big problem, so we have a list of things up here. And a new kid on the block that we're all going to start hearing about is rusfertide. So, which is a medication that's kind of like a therapeutic phlebotomy and an injection, which is interesting. But it works by taking iron away from red blood cells and redistributing it to the rest of the body. And in that study, not only was hematocrit nicely controlled, but symptoms were improved. And so it's possible that if you are somebody who's got a lot of symptoms, especially if you have iron deficiency with polycythemia vera, rusfertide may be a good option for you, at least in the short term. And Rupali, what other kind of closing out here, right? So I think we're...
Actually, you have a slide on this, so
Oh, okay.
go backwards to your risk of co-occurring cancers with MPNs.
This next slide? Okay. Yeah. So we were just going to do one slide on this. So we know that in all of our MPNs, ET, MF, PV, there is some risk of transforming to acute myeloid leukemia. But we also know that MPN patients are at about 1.5 to 3-fold risk of developing other cancers, including lymphoma, skin cancer, kidney cancer, lung cancer, and thyroid cancer. Still trying to completely tease out why, but some of the kind of combination of factors may be. So maybe you have a genetic predisposition, the same kind of mutation that kind of caused your MPN could then also later cause a second cancer. Maybe it's a cytotoxic drug that you were on. Hydrea, we know, is associated with an increased risk of non-melanoma skin cancer. We've talked about inflammation a lot, so sort of that overactive proliferation of cells and that overactive or hyperinflammatory state that is present in all of our MPN patients that can then kind of increase that risk for yet another cancer. I think this sort of inflammatory state is sort of a breeding ground for things like malignancy. And then we also know that probably the immune system of patients with MPNs is a little bit wonky. So, our immune systems are constantly kind of trying to catch mistakes and prevent sort of, overly speedily dividing cells from happening, but sometimes those sort of checks and balances fail. So maybe it's sort of an inability to detect that second tumor that's developing. So I think in general, we all counsel our patients to make sure that they are staying on top of all their age-appropriate screening, mammograms in our female patients, colonoscopies in all of our patients. And we just have to be vigilant sort of to pick up on signs or symptoms that may not be related to the MPN, but may be a sign or symptom of a different kind of cancer brewing. Do I do any extra screening necessarily? No. Do I, whole body scan my patients? No. But again, you just sort of, I think you just sort of remind yourself to be just like a good internal medicine doctor and ask all the symptoms. And, I think we want to definitely hear our patients, and we know that our disease can cause a lot of symptoms. So I never want to poo-poo symptoms and say for sure that they're not related to our MPNs, but we need to forget that our patients also truly get other things. So we just want to be mindful and, work things up if it doesn't quite fit as being attributable to our MPNs. I will say that usually I have a low threshold for just recommending that my patients go to derm once a year, especially if they're on Hydrea, and get one good head-to-toe skin exam because I don't trust my mole reading capabilities. And so that's the one kind of extra layer of screening apart from the routine mammograms and colonoscopies that I usually recommend. And then, again, controlling, making sure that, if I have a smoker, then really trying to, counsel my patients who smoke to, stop smoking, stop chewing tobacco, in our younger patients, maybe HPV vaccine, et cetera, et cetera.
Yeah, I've had patients tell me that now they have an MPN, there's no reason to have their other cancer screening, and I'm like, you're going to be around, we're expecting you to be around for at least a good decade. Please keep up with this. It's super important because you are at slightly increased risk of these other things as well. And so, but I do the same thing, just the routine age and gender appropriate cancer screening. And again, that's really important to partner with your primary care doc because honestly, they're going to be the ones who are ordering these tests for you. It's just a little too much to keep up with in the subspecialty clinics.
Any other questions at this time?
Is there a way to educate your dermatologist
Yeah, I mean, I really kind of am depending on their eyes to catch.
Like a handout, you can't hand to them and say, this is what you need to look for because I have, have this disease and I'm taking this medication.
Yeah, I
Bring
mean,
something else like that?
Oh, yeah.
You know?
That's interesting.
Yeah.
So I guess because most of my stuff happens within my institution, the dermatologists actually are absolutely fantastic.
I might
Um,
though.
And so, yeah, but it's really the non-melanoma skin cancers that we're looking for. So, yeah, if you're finding that to be a problem, we'd be happy to kind of come up with a little pamphlet that might help you talk to your dermatologist about this.
Yep, just maybe put it on the website so that we can print
A
it.
few more minutes, because then, we'll stop and take a break and then hear from our industry partners. And then we'll break the group into PD, MF, and T.
Okay.
So any other questions, or do you have another slide you want to go over?
Well, so I think if we do have a few more minutes, the last thing we wanted to touch on was, did I inherit, like, can I pass this on to my children, right? So we get this a lot. And so the answer is sort of. So MPNs are not something that you were born with, but it's the result of a mutation that happens over time. So it was not passed down from mom or dad, but it's kind of curious because it's sort of like breast cancer or colon cancer, where you might be born with an increased risk to develop this. So you may pass on then an increased risk to your children, or your siblings might have an increased risk, right? Your parents might have an increased risk. But it doesn't mean that there's an absolute that somebody is going to develop an MPN in your family. And so the increased risk is roughly 3 to 5-fold in your first-degree relatives increased. So when you talk about rare diseases, it's still going to be pretty rare overall, right? And the big question that comes up all the time for me is, so do I get the JAK2 testing or do I get the CALR testing from my family members? And at least my practice right now is no. So we're not sure when the mutation is going to develop. Our screening is now getting quite good to pick up these mutations so we can get them really low. But just a few years ago, we couldn't get super low, so you might be missing the mutation before it's high enough to actually detect. So what I recommend is in your children, especially adult children, right? So there's really not a lot of reason to be doing this, especially under the age of 18. Annual blood counts, which you would think are part of your annual physicals, but turns out it's not in the majority. So an annual complete blood count and just kind of watching for symptoms. So, right, educating about, are you having unexplained itching, right? Are you super tired? Is your spleen big? All the things that you know in yourself can happen. So the short answer is no. They're generally not directly passed down, but there can be an increased risk in families. I don't use mutation testing. I just recommend CBCs. I'm not sure what you do.
No, agreed, 100%, same. Yeah, I do not, I agree, just screening for counts and symptoms.
So, I do have a question about that, because over the years, we've had audiences with 5 people in the family that all have an MPN. And I know Angela Fleischman and Dr. Wadley, Martha Wadley, had done familial studies, and somebody else's, maybe Brady Stein, somebody's looking at it. So let's say you do have someone come in and they have 3, my mother had this, I have this, and my daughter has this, what's the answer to that question? Or is it what you said, that, the susceptibility or something?
Yes. So in those cases where we have a known family history, and it could be a different blood cancer, right? It could be a lymphoma or a myeloma, or weirdly, melanomas. There are some solid tumors that can get associated. So that sets off, in my mind, a potential gene that is a cancer predisposition gene. And so I actually take a good family history and generally refer patients to our genetics department for consideration of additional counseling and then maybe mutation testing to see if we can identify what predisposition gene is there. That's a fantastic question and point, Anne.
Well, over 23 years I've been in this space, and I will tell you that I hear from families all the time that say, well, my uncle had it, or my grandfather had this, or,
Yes.
So it's a question, I'm glad there are studies out there.
Exactly.
I know Angela was doing a big study on this because I was sending her people constantly.
Yes,
But
it's
it is
becoming.
interesting.
Yeah, it's becoming increasingly better recognized as we're taking better histories, and right, people are going to the doctor more frequently and actually getting their diagnoses instead of, well, they had bone cancer. Was that metastatic lung cancer? Like, what was that? Was it really bone cancer? Was it myeloma? And so, yeah, we're recognizing that more and more frequently. Is that your practice too?
Yeah, we're really lucky to have a really good genetics department as well. I always pick up the phone and refer patients with, in particular, that kind of history. Yeah.
So I have one last question. I'm sorry, I can't help it because I don't get to see you all very often. But what hope, we interviewed Jane Fonda, I think you were there a couple of years ago, and I said something about, what would you hope for the future of the women in this room or the people in this room? And she said, I've turned hope into action. And I loved that. I thought it was a really nice quote. But what wisdom would you impart to these people here today that gives them some hope for the future in MPNs?
Yeah. So, it's never great to get a disease, right? But if you look at the trajectory of what's happening over the last decade in MPN, it is astonishing. So the discovery of JAK2 really was a huge opening in the field. And then the calreticulin studies, right? So Dr. Elf, it's just amazing how we're getting into precision medicine, and we're really learning how to target these mutations. There is some really cool stuff in the pipeline that I hope we're going to hear about in just a little bit. And so it's not all doom and gloom, right? So it used to be watch and wait. Like, watch and wait for what? Watch and wait for me to get AML? No. We're moving out of that era, which makes me so happy, and moving into one where I think there's a ton of hope, where we're going to, this is going to be a totally chronic disease that hopefully never changes, and maybe even one that is like CML, where we're low-key getting it, right, in deep molecular response, which is AKA potentially cure, right? This is exciting. And I think just like Jane Fonda said, now, so there's a lot going on in science and medicine, as you all know. It is super important to voice your opinion to your local representatives about what you want done, because I'm telling you that we are losing money, we are losing funding for this, for the science that's going on. It is a really big deal, and it's a dark time. Right now, we're not exactly sure what's going to happen, and so there's some progress that has gotten us this far, and I hope that we carry that forward.
I hope that the patients that are on Medicare in this room look at that as well, because you may be losing coverage. Something. So, yeah.
Yes, absolutely.
No, I mean, I couldn't have said it any better. No, I agree. I think, yes, very important to voice your opinion about continuing progress in science in general, and agree in the last decade, MPNs have become, more and more and more kind of to the forefront, more interesting. I think the conversation has shifted a lot to actual sort of coming up with therapeutics that are not just transplant, that are that can change the biology and the trajectory of the disease, as opposed to just improving symptoms. And so I think that's more and more a conversation about that comes into play now in terms of clinical trial design. Let's not just sort of see who can, have spleen reduction, symptom reduction, but let's look at, leukemia-free survival, overall survival. So yeah, very exciting.
And I do want to show you our final slide.
Oh, yeah.
Okay. So we did not have any photos together. And I saw Ruben's slides, and I was like, wait. So I asked AI to generate this for me. But AI is so mean. So that photo of me is totally touched up. Like, there's a lot of stuff that it did, and I was like, oh, come on, AI. That is us. We are the, underdog comic relief here. And seriously, though, if you need us for anything, we're around. Please ask us questions. Feel free to email me, and we're happy to talk to you anytime. Okay.